So welcome everyone again. Appreciate you joining us. We're here today, Kids Mental Health, Pierce County, Marybridge Children's and Washington State Healthcare Authority to talk about family-initiated treatment. You can go ahead and use the chat or the question and answer box to ask questions that we can have answered at the end. If there are additional questions, I am going to go ahead and turn it over to Monica or Lisa to go ahead and get us started this morning. Thank you so much.
Yeah, thank you so much, Vanessa. It's such a pleasure to have an opportunity to connect with you all today. My name is Monica Webster, and I am the Access to Care Family Initiated Treatment Manager for prenatal to 25 and school age for the Healthcare Authority and the Division of Behavioral Health and Recovery, also known as DBHR. I'm joined today by my wonderful colleague, Lisa, and I'll give her the space to introduce herself.
Good morning. My name is Lisa Westland, and I am the Involuntary Treatment Act Administrator for the Healthcare Authority. I oversee anything that's related to what is RCW 7105 for adult involuntary treatment and 7134, which is adolescent with regards to adolescent inpatient treatment for involuntary care.
Thank you so much, Lisa. So I have, full disclosure, been having a bit of technical difficulties this morning, working very closely with our wonderful IT team. So while I'm going through the PowerPoint, I'll turn off my camera just to make sure that there isn't any unnecessary interference, and then I'll turn it back on as soon as I'm done with the PowerPoint, if that's okay. Can everybody see the slide on the screen right now? I'm hoping. Okay, excellent. That's great. Thank you so much. Thank you. So yes, thank you, Lisa, for sharing. Just a few housekeeping things, and we have 30 minutes together today. And my plan is to give a high-level overview of it. And Lisa will provide information, as she mentioned, on the inpatient aspect of FIT. And one key thing that I like to emphasize at the beginning of the trainings is that I encourage each organization that I speak with to consider whether or not FIT is a viable option within your specific organization. Ultimately, it's up to each organization to determine how or if FIT is an option. And today, I just want to make sure that I extend that invitation to all of you to explore. Additionally, I want to clarify that I'm not able to provide any case-specific guidance or legal advice. So if you have questions along those lines, I strongly encourage and recommend that you consult your legal or compliance teams to make sure that you have the appropriate support that you need. All right, so jump right in. So I'm sure that most of you have heard of family-initiated treatment, but I just want to also make sure that for those who haven't, that I provide a snippet of historical context. So family-initiated treatment, also referred to as FIT, provides an opportunity for you to receive behavioral health care when they're unable to provide consent for themselves from the ages of 13 to 17 under RCW 7134. I know that many people refer to FIT as a program. However, it's actually not a program, but more of a pathway that allows parents the ability to consent to treatment on behalf of youth within that age range who meet medical necessity. And we'll explore some definitions of parents on the next slide according to the RCW. So FIT was originally developed in part based on recommendations from the Parent-Initiated Treatment Stakeholder Advisory Group, also known as PIT. You know, we love our acronyms. And this group included input from youth, parents, clinicians, hospitals, emergency departments, and child system advocates. So PIT was designed to support acute inpatient evaluation and treatment and has been a long-standing model. Over time, it's evolved into FIT, family-initiated treatment, which now offers a pathway for outpatient evaluation and treatment along with other guidance aligned with the FIT legislation. So the findings and the recommendations from that stakeholder group were presented to the Children's Mental Health Work Group in December of 2018. And following that, in 2019, the legislature enacted Ingro's second House Bill 1874 to formalize and support these efforts. So this provides some context on how PIT evolved into FIT and how we're currently utilizing FIT in practice today. So
I just want to
know if
pause really quickly. There
Yes.
was a question asking about the slides, if they're supposed to be progressing.
Not yet. So they're
Okay.
just, yeah, thank you for the question and thank you for letting me know there's something in the chat because I can't see the chat.
Yeah, no problem. Yep, no problem.
But yes, thank you. I just wanted to make sure that I gave kind of that overarching picture before I sort of dove into the slide. So thank you so much.
Very helpful. And then one other question around if they're going to be shared, if you're able to share them. Okay, great.
Absolutely. I was planning on sending that to you, Vanessa, so that you can send them out and make sure that anyone who would like to access those can. And then there's also links that I have available, hyperlinks at the end of this presentation as well. And so those should be available as well for folks to access.
Wonderful. Thank you so much.
You're welcome. So the definition. So I'd like to quickly go over just a couple of key definitions that are frequently used when we're talking about FIT. So first, youth, which refers to adolescents aged 13 to 17, as I mentioned earlier. And second, parent, which has a much broader definition and includes not only a birth or adoptive parent, but also step parents, kinship caregivers, DCYF caseworkers, relatives responsible for the youth's healthcare decisions, or anyone who's been given a signed authorization by the parent to make healthcare decisions on behalf of the youth. Our goal here at HCA is to deliver the best possible outcomes for youth and their families. And so to achieve this, we wholeheartedly embrace these three core values. First, recognizing and building on the strengths and needs of the youth and their families. Second, striving to provide services within the youth's own community whenever possible. And third, ensuring that our services are culturally and linguistically responsive. As we all are well aware, effective communication is essential. It's crucial that we connect with each other in ways that genuinely understand the needs and concerns of the youth that we serve, while also being mindful of where they are in their process of change. So two really big things to remember, and you'll hear me mention repeatedly throughout this presentation, is that one, treatment works best if the youth engage in the treatment, the ultimate goal being to engage youth in services that they're receiving so that they can consent to continue treatment as needed. And two, whether treatment is voluntary or not, the youth always has the right to receive services in the least restrictive setting that meets their needs. Engagement. So treatment is most effective when the youth is actively engaged in the process, as I mentioned earlier. While there are some situations where treatment is medically necessary to ensure the safety of youth or others, we know that it's more likely to succeed if the youth chooses to participate. And FIT provides parents and professionals with an opportunity for time-limited treatment during which parents can give consent on behalf of the youth. The primary goal here, again, is to involve the youth in their treatment, encouraging them to consent to the ongoing services as needed. It's important to note that the youth have the ability to change their minds, either voluntarily consenting to treatment later or being involuntarily treatment authorized, ITA'd, the acronym, if necessary. Yeah, so to help kind of clarify the process for accessing outpatient FIT services, I thought it might be helpful to include a chart outlining the general steps since we do get that question quite a bit. So the process begins with the parent requesting services. The provider then evaluates the medical necessity of the services. The parent signs consent on behalf of the youth. The provider sends a notification of admission to HCA's reviewer, and then HCA's reviewer conducts a review of medical necessity every 45 days, and services continue under FIT as long as the criteria are met. Yeah, for inpatient. So the process for inpatient treatment differs slightly in that the provider must notify the youth's admission within 24 hours. And following this, the youth is informed of their right to petition. Afterward, there's a review of medical necessity conducted on day 10. And it's just really important to keep in mind that the maximum length of stay under FIT inpatient is 45 days. That's another question that we get frequently. So I just wanted to highlight that here as well. So in addition to the inpatient information that I just shared, I also want to highlight the criteria that our FIT administration uses to assess eligibility for accessing FIT inpatient services, because that's another frequently asked question. And the criteria are as follows. The youth has a diagnosis of an emotional or behavioral disorder. The required treatment can only be provided through inpatient services. Community ambulatory care resources are insufficient to meet the youth's treatment needs. And the services are reasonably expected to improve the youth's functioning or prevent further regression. So furthermore, there's a specific form that must be completed by the provider to access outpatient services. And I have attached a link to that form for your convenience as well. It's also going to be available in the FIT guide that's in the resource section of this PowerPoint as well. What information can be shared? Yeah, so this is often a sensitive topic that comes up with parents and guardians of youth who are accessing behavioral health services. And as we all know, we have to adhere to HIPAA guidelines regarding the age of consent. To support parents in helping their youth with treatment, providers may choose to share certain information, and that information can include diagnosis and treatment recommendations, the progress in treatment, information about prescribed medications, including their benefits, risks, side effects, and dosages, crisis prevention strategies and safety planning, referrals to additional community services, and training or coaching for parents that could benefit both the youth and their family. So it's really important to have family supporting the youth through the treatment because they're essential partners in the treatment process. We encourage families to be a part of the treatment plan. Recognizing the entire family has been impacted and may benefit by being a part of the treatment process. So participation in the treatment process can really benefit not just the youth, but the whole family system. Examine their own fears and anxiety and how those may have an impact on the youth and how to reduce that impact. Families should explore how their own fears and anxieties might influence their child's behaviors, because understanding this can help reduce unintended impacts and support healthier interactions. Strategizing supports outside of treatment for the youth and respect for the youth's privacy is essential. It's really important that families understand that not all information can be shared by professionals, and this is really to protect the youth's confidentiality. Yeah, so in 2020, the Healthcare Authority carried out a system impact survey over the course of 1 month to assess the effects of the rollout and the implementation of FIT. The survey gathered insights from youth and parents and providers, and I just want to take a moment to share a few highlights from those findings. As you can see from the information provided on this slide, that youth felt that having supportive family members and school counselors was helpful when they were seeking services, and identified that barriers were around cost, just as many of our partners have identified. As far as parent perception, 40% of parents somewhat agree that FIT has helped young people access the services they need, while 36% strongly agree. Our goal is to really increase these numbers, and we're using opportunities like this to foster more conversations about how parents can access services. Now, in terms of parental support, 27% of parents somewhat agree that FIT benefits parents of young people in need, with 47% strongly agreeing. However, 50% of parents expressed concern, as you can see, that FIT may not provide enough support for parents, and 56% of parents indicated that they're not worried that FIT violates the rights of young people. Yeah, the provider perception. So you can see from this slide that 32% of providers said that they did not feel there was a lack of education around using FIT, while 28% felt there was a significant barrier. 40% were not concerned about the legalities around utilizing FIT. 51% did not see the use of FIT being a barrier with regard to their workload. And 68% of providers did not feel there were barriers around billing. So this is why we've been actively promoting awareness of FIT across communities and groups and social media, as well as encouraging opportunities for questions and feedback, because I recognize that FIT can be quite complex. So, if questions come up that I don't have an immediate answer for today, I'll make sure to follow up with you once I have the necessary information to get back with you on that. So all of this data basically and feedback clearly highlights there's still work that we need to do. And we are working to create more opportunities for dialogue and connections like these with the hope that it'll lead to greater access and increased comfort in utilizing FIT. This also involved clarifying how FIT intersects with programs like CLIP, WISE, ABA, ambulatory care, and substance use disorder treatment. We get lots of questions around the intersectionality of FIT in those programs. So at the end of 2024, I submitted a final legislative report that outlines these requests. So there will be more updates on those asks in the future. So I want to share some of the successes that we've had with FIT. So we've created an internal FIT dashboard to monitor and manage FIT activities effectively. Then I'll share some data with you in a bit. There's now a FIT guide, as I mentioned earlier, that's been developed to serve as a resource for providers, parents, youth, and community members. So all updated FIT-related paperwork and documents are housed here, as well as any updates to the legislation as well. Our team is engaging daily with community members to foster relationships and gather feedback. We've developed specialized FIT training modules, which has also now been translated into Spanish. Yay! And I know that many of you have accessed those prior to this training. So I'm really curious to know what you thought about those. They really go into depth about FIT from a provider perspective, a parent perspective, and a youth perspective. They're self-paced and they are completely free to the public. So feel free to share that link, share that information with anyone who you think might be interested in those. And we've had about 1,500 people enrolled so far, and we've received pretty good feedback about them. So feel free to share, as I mentioned, share that information with whom you think might benefit. A QR code has been created to facilitate easy access to those trainings as well, so you can just use your phone to access them. A marketing campaign was launched in collaboration with our communications department to raise awareness and promote the benefits of FIT within the community. And to better serve our more diverse population, select printed materials have been translated into additional languages. And we're actually right now working on having additional materials translated as well. So really looking forward to that this year. Lastly, we're actively engaging in conversations to explore the possibility of implementing a FIT provider opt-in option. So this would allow providers to voluntarily choose to identify themselves as FIT evaluators. And I know that that has been an ask from our community as well. So in terms of data to date, since the implementation of FIT from January 2020 to through April 2025, there have been 3,222 FIT admissions, 410 FIT reviews, 57 SUD or substance use disorder admissions, and 20 SUD reviews. So yeah, there's always opportunities to grow and learn. And And we've identified 3 overarching categories, and I've also highlighted these in the legislative report in 2024. Increasing youth, parent, and provider voice. So we recognize the importance of actively involving youth, parents, and providers in the development and refinement of our programs and pathways by elevating their voices and ensuring that the services are more responsive, relevant, and effective for those we serve. The big ask is to secure additional funding, because additional funding allows us to expand and sustain our initiatives and increase resources so that we're able to reach more individuals, but also implement innovative approaches to care. And the last big ask is for more training and education, because this will not only improve service delivery, but also provide our community with the knowledge and skills that are needed to support positive outcomes. Yeah, so I know that I mentioned a few times about the legislative report that I submitted at the end of last year. And this slide just really captures our asks. We're committed to continuing our support by offering ongoing training and technical assistance to providers to ensure that organizations have the resources and knowledge needed to effectively implement and sustain FIT. And part of that effort includes accessibility. We would like to expand our training and education materials to include additional languages, which is something that we're actually working on this year, and I'm very excited, so that we're able to broaden our reach. And exploring the nuances of the evolving delivery system so that we're able to adapt and find effective ways to integrate FIT within these new frameworks. So yeah, here are a few resources that you might find helpful here. And I mentioned that there are hyperlinks. They're hyperlinks, so you can just click on them and they'll take you right to the pages there. The QR code is also available on this slide deck as well. And this is my contact information. I've also added it to the chat. So you can feel free to email me. Community members can email me if they have questions or inquiries, or would like to have a training. I'm more than willing and eager to engage with community members, excuse me, in different groups. And I've also listed the FIT administration contact information. So if you need to reach out to them, that is the email that you can use to reach out to them as well. And then I'm going to add a couple of things, additional things in the chat. But yeah, I will, that's all that I've got as far as the slides, and I will stop sharing and turn it over to Lisa.
Monica, one of the questions that was asked is if you could explain similarity or difference with regards to FIT and the WISE program.
Right. So WISE is the youth has to consent. So that is the difference. You can't force it as a youth to engage I believe in the WISE. I'm not a WISE expert, but it is my understanding that they do have to consent. And that's the big difference. I don't know if Lisa has any additional information on that, but as far as I am aware, that is the big difference. And it looks like Tina can also speak to that. Thanks, Tina.
Oh, she might be muted.
Oh, how do I unmute? Can we unmute Tina Burrell, please? Vanessa, is that possible? I don't see.
Tina, try. Tried to unmute and it's not.
I don't, and in this format of the webinar, I just want to double check. I can't switch it in the middle of it, so I can't. So if you could ask the questions in the question or chat.
So Another participant indicated WISE is intensive outpatient treatment for youth with Medicaid, and youth need to consent to engage in this service.
Mhm.
And so
Thank you.
that's similar to what Monica was indicating. And WISE, it has like different levels of service requirements to the programming. So that includes, medication management and service engagement, whereas FIT can be one level of service depending on how the outpatient provider wants to set up that level of treatment. So it can be more intensive or less intensive. That does happen with WISE as well, but with FIT, it's more of a, let's start out with maybe just individualized therapy to work through some of the dislike of doing therapy. And then another question is the process for SUD service referral the same as for mental health with FIT?
So Amanda Lewis is our subject matter expert on SUD, and we get a lot of questions about the interaction or intersectionality between FIT and SUD. And oh, there we go. So it looks like we've got some folks who are chiming in. There we go. Thank you so much.
And
And
Tina's able
and
to share, and I can switch to presenter mode if you need to speak. I've found a way. Thank you, whoever spoke.
excellent. Thank you. It looks like Tina, you can speak if you'd like.
Well, we have wonderful folks in chat sharing answers for us, and good afternoon. Wonderful presentation, Lisa and Monica. I'll just say, I think simply, FIT is the pathway to have access. It's another pathway to access outpatient and inpatient services, as Monica said. And WISE is actually, an outpatient service delivery model. Folks sometimes call it a program, but it's a service delivery model. And WISE is voluntary, it's team-based. We want folks and family members and natural supports to lean into the process. It doesn't exclude FIT from making a referral to WISE, but if you are in the provider network at all, there's a really long interest list. And so we do want FIT to have access sooner than you might be able to have access to a WISE team. So that's what I would add to this work. If there's more information, Monica and I are happy to follow up on WISE specific. Appreciate the WISE question.
Yes, thank you. It looks like there's another question in chat, but I do want to make sure that Lisa has a chance to chime in if that's okay with everybody. And then we'll hold the questions just for now. And then anything that we don't get to, then I will circle back in an email to you all as well. That's okay. Go ahead, Lisa. I apologize for the delay.
No problem. It happens. People always have really good questions. So Monica touched on aspects of the involuntary process for FIT. Things that people need to keep in mind with regards to FIT at a local emergency room level is it is an option that is available for parents and caregivers to utilize for access to treatment. That one, as Monica indicated, it has to be that providers identify it as being medical necessity. And when we're looking at levels of acuity, it's not always going to be a circumstance where it meets the highest level of involuntary treatment. So it's not a situation where it would be that the youth would need to have a designated crisis responder come in and evaluate and have them be placed on an involuntary hold. So the hospital is to provide information to family and to caregivers that lets them know about the option of utilizing FIT for inpatient treatment. The benefit to that is that if there is a circumstance where that is an option, that allows that hospital to hold on to that youth for a longer period of time while they seek an inpatient admission. If it was, that they make contact with the designated crisis responders office and say that they would like to have an Involuntary Treatment Act investigation, that youth, if they were brought in by parents, can only be held for a period of either 6 hours or 12 hours, depending on what the circumstances are. And so that limits the hospital's ability to hold that youth legally under the RCWs, whereas FIT allows the hospital to hold them pending placement because the parent under FIT is providing that consent. And then the inpatient facility is the one that goes through the process of providing and determining the medical necessity and submitting the information to the HCA for doing that FIT admission. So that is the main pieces of that. And Monica is putting in the provider toolkit and the provider guide, which really goes into describing a lot of those details. Gregory asks in the chat, what if the patient is not able to remain in the hospital safely under FIT? And so if you have an individual, if you have an adolescent that is in the hospital and their acuity is such that FIT is not a viable option, and the provider is thinking that they're going to need treatment for longer than that, you know, they've had that review and they've been approved for FIT, and then there's that 30-day consideration for ongoing treatment. If during that 30-day period, the treatment provider is concerned that their level of acuity is high and they're starting to consider that this youth may need to go to CLIP, then they need to begin the process of discussing a CLIP referral, and they need to begin the process of discussing having a designated crisis responder come in and perform an ITA investigation to start the involuntary process. Because CLIP admissions are only voluntary consent by the youth or involuntary petition process. Those are the two methods by which CLIP referrals occur. FIT is not a permissible referral source for CLIP. And so the question is this before they're transferred to the acute behavioral health unit?
I think that the question, what if this is before they are transferred to an acute behavioral health unit? So for the initial referral, for instance, if a young person's parents are willing to sign someone in for FIT to acute inpatient, but they're not safe, could run higher acuity, something under those lines, and it's voluntary, so there can't be, they can leave the hospital if they choose to leave the hospital or attempt to. Would you recommend?
So the parent or guardian is providing consent for the admission. The hospital is responsible for providing supervision during that time for that transfer, just like they would for, you know, someone who is elderly that they're needing to transfer into another care facility. I mean, they still have to supervise any patient that is in their facility. So, you know, that monitoring between that period of time still needs to happen, just like if it was that this was an involuntary process for any individual, they still have to provide that supervision. You know, the question would become for that facility is the youth doing something that raises the level of acuity such that they would like to consider that this would be, you know, from the beginning, that the acuity is so high that they're fully aware that this is going to need to be like really we're going to get them into an inpatient facility, and we are going to be pursuing a CLIP placement. Oftentimes, those circumstances are where the youth has been evaluated by outpatient providers in the community. It's a situation where CLIP has been discussed by providers in the community already. So people are already kind of aware that this youth is going to be sent to the emergency room, you know, for a DCR evaluation for involuntary treatment. So it's an expected process. Since the wait time is so long for a CLIP bed and the extended process, sorry, my screen moved.
Let me see if I can.
Does this put them at a higher priority on the wait list? No. So the CLIP wait list is like any other wait list. It works in its own fashion. So for any form of involuntary treatment, the process is always a stair-step process. So the individual has to have an initial evaluation and initial detention. So that's what we call the 120 hours is an initial detention. Then they have a probable cause hearing, which determines if they will be held for up to 14 days. During that period of time, they're further assessed and evaluated and determined if they can be civilly committed for a period of up to 180 days. So for youth, it's initial 120 hours, not including weekends and holidays. Then it's a 14-day civil commitment, and then it's a 180-day civil commitment.
All right. Thank you so much, Lisa. I am aware of the time, and I just want to thank everybody for their time. Thank you, Lisa. Thank you, Tina, for joining me here. And thank you to all of the organizations and folks who are on the call. If you have additional questions, my email is in the chat. I'll actually put it in there again at the bottom just so that it's visible again. But you can feel free to email me directly, and I will forward the presentation to Vanessa, and hopefully Vanessa will be able to send this out to you all as well. Right. And yeah, so thank you all so much for your time.
Thank you.
Thank you so much for
All right.
joining,
Thanks,
everyone.
Vanessa.
Yeah, absolutely. Thank you, Monica. Thank you, Lisa. I
Yeah,
really appreciate
of
it.
course.
And likely there will be more trainings to come with Mary Bridge Children's and Kids Mental Health Pierce County, possibly more on involuntary treatment and navigating some of those processes as well. I will share the slides out with the Kids Mental Health Pierce County team and all attendees. So thank you so much for joining us. Thank you for all this information. They're challenging systems to navigate, and the more we can connect and more we can collaborate to support our youth and families, the more supported they are. So thank you so much for sharing. Thank you everyone for attending, and I will send out these slides to everyone. Thank you so much.
Thank you.
Thank you.
Bye,
Bye-bye.
everybody.